See if he's on.
Get ready in 1 second. We're calling the Cook County Health and Hospital System Finance Committee meeting to order. Will the secretary please call the roll?
Director Green? Present. Director Harrington?
Present.
Director Lowry?
Present.
Director Robinson?
Present.
Chair Taylor? Chair Ryder?
Ryder is here.
Sorry. You have a quorum.
Do we have anyone? Okay. The next regular meeting of the Finance Committee is scheduled for Thursday, September 11th at 10 a.m. Deb, are there any registered members of the public who are providing in-person or virtual testimony?
We did have one registration from Wendy Fowler. Wendy Fowler, are you present? I don't believe she's present.
Okay. Was there any written testimony provided?
No.
All right. We'll next move to our July 17, 2025 Finance Committee meeting minutes. These were approved at the July board meeting, but are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes? Any corrections? Any corrections? Hearing none. Is there a motion to accept item 3A, the July 17, 2025 Finance Committee minutes?
So moved.
Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing no discussion on the motion, all those signify by saying aye.
Aye.
Opposed? The ayes have it. Do we have every person here on the committee?
We do.
That's great. And we always have good participation,
We do.
so, because of our meetings. That is not true. That is not true. That
You're
has
like a
nothing to do with me.
magnet.
That's to do with the quality of the people on this committee. We also have the August 5th, 2025 Finance Committee special meeting minutes. These minutes introduced the proposed Cook County Health Fiscal Year 2026 preliminary budget of the Special Finance Committee convened on August 5th, 2025. Our public hearing on August 11th, 2025. 10 members of the public provided testimony and 3 written testimonies were submitted. Our public hearing on August 13th, 2025, 5 members of the public provided testimony and 1 written testimony was submitted. The written testimonies submitted are also included in the minutes and are part of the meeting record. This meeting was held for informational purposes. There were no action items considered in this meeting. These minutes are being presented for approval. Are there any corrections that need to be made to these minutes? Any corrections? Any corrections? Hearing none, I would accept the motion to approve item 3B, the August 5th, 2025 Finance Committee's special meeting minutes. Is there a
So
motion?
moved.
Motion's been made. Is there a second? Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. Review and consideration of the proposed Cook County Health Fiscal Year 2026 preliminary budget. We're going to do a review of the slides by Pam Casara, our Chief Financial Officer, Scott Spencer, our Associate CFO, and Joseph Francois, our Budget Director. Following the review and discussion, if the committee chooses to approve today, that would be a recommendation for approval by the Finance Committee to the Board for the August 22nd meeting, contained within the minutes for this meeting, presented to the Board for consideration of approval on August 22nd.
Good morning.
Hold questions to the end unless something really strikes you, and we'll be happy to address it. Okay, so again, we're going to take you through our accomplishments and our key initiatives, go through some history, go through the budget, touch on our special purpose fund, and then wrap it up. All right. So again, there's lots of accreditations and awards and recognitions listed here. The ones that especially impact the budget are related to expansion and growth and optimization efficiency efforts that either impact our revenues or expenses. I think we've seen this enough times. The ones that affect numbers have been highlighted. I won't read through them again. You have them in front of you. Next slide. Moving on to next year, again, there's numerous efforts related to improving quality scores, patient and employee satisfaction, and achieving various awards. But the ones to call out that affect budget numbers, again, are highlighted here as well. I'm not going to read through them again, but there are a lot of efforts underway. Next slide. All right, history. The CCH FTE trend. This slide shows the budgeted fluctuations and trend over the last decade. The call out here is that we are bringing on 110 FTEs over this year, which is primarily related to bringing previously ARPA-funded positions onto the health fund. Next slide. This busy slide shows our volume trends over the last several years, and you can see some of the key stats that drive our revenues have seen slow but steady growth, while others have remained pretty flat or even been declining. Next slide. Once again, just to touch on the federal and state funding cuts that we're facing and the preliminary estimates of the impact to CCH. Again, the one known impact at this time is the state sunsetting of the Health Benefits for Immigrant Adults program. That's over $100 million estimated impact to us annually, and that has been budgeted into the fiscal year 26 budget. We're staring down some significant DISH cuts, absent any congressional action this fall. That has not been put into the budget. We'll address that through the amendment process if necessary, as more becomes known. And then out in the out years, starting in 2027, there's 2 more rounds of cuts, Medicaid related to Medicaid work requirements and Medicaid redetermination, moving to every 6 months rather than annually. The compounding effects there, of course, are that we're going to see more uninsured. The demand for care at CCH is going to go up. Charity care costs are going to go up, and access to care is going to go down. Next slide. So here you can see that we've enjoyed that favorable surplus the last several years with revenues exceeding expenses, but that is projected to change in the out years as we have normal salary increases, supply cost inflation, and those pending additional Medicaid cuts come into effect, creating a deficit for the health system. All right, now I'm going to turn over to Associate CFO Scott Spencer to run through the budget.
Okay, thank you, Pam. Good morning, directors. So, starting with our FY26 budget assumptions, we first start with seeing what our run rate is for FY25 and projecting out from there, and then adding and subtracting based on where we think we're headed. So, starting at the top here, we've got the 10% expense reduction that was put into place for FY25 that will carry over into the FY26 budget. We've got additional GI and crisis stabilization volumes at Providence. We've got a charge master increase as well as Medicare and Medicaid rate increases. We've got capitation rate increases. We have expected salary increases, and we have a expected reduction in the county care membership. Next slide. So our volume assumptions here, showing basically translating into the numbers, the different volume, the volumes that we've seen. So surgical cases are expected to increase at Providence, again, due to the GI volumes. We've got ER visits lower than FY25 because we don't expect the volumes associated with the new arrivals. However, we're budgeting FY26 flat to FY25, as we might see some increase in ER visits as patients lose coverage. And then finally, towards the bottom, we have average daily census, just pointing out a decrease from 326 to 306, which is mostly driven by an improved length of stay. But by and large, our volumes are expected to be flat. So on the next slide, we have total revenue coming in at $5.144 billion. The various revenue streams, starting at the top, is our net patient service revenue coming in at $581 million, which is a $264 million decrease from prior year due to the Medicaid impacts that we've already discussed, including redetermination and the elimination of the health benefits for immigrant adults.
Scott, I'm sorry to interrupt. Can you place your microphone? They can't hear you on the remote.
Let's just do that. Is that better?
Yes.
All right, sorry. All right, so we've got our governmental support, which includes DISH, BIPA, GME, and directed payments, seeing an overall increase due to directed payments being under budget in FY25. As Pam stated earlier, we aren't budgeting any DISH cuts, and we're eagerly awaiting what Congress decides to do here in the next couple of months with continuing to delay those DISH cuts. Health plan services, you'll see a $168 million increase in revenue. So while we are expecting a decrease in the membership, we also expect increases in the capitation rates. The tax allocation is increasing by $10 million due to the county agreeing to increase the allocation to mostly cover the ARPA positions that are shifting to the health system. And then the other revenue, which is mostly retail pharmacy, we expect a $9 million decrease. Again, the retail pharmacy being impacted by the federal and state policy changes to Medicaid as are other service lines, or revenue streams, rather. Next slide, you can see the health fund expense, again, coming in at $5.144 billion, as we, as always, are submitting a balanced budget. You can see the expenses by office, and in the variant column where we've taken expense out of the health system, again, due to the initiative to close the budget gap in FY25 and that carrying over to FY26. On the health plan services line, you'll see $210 million increase in expense that I referred to earlier. And then on the far right, you can see the FTEs, 110 FTEs additional coming into the health system, again, which are mostly the ARPA positions. So budget at a glance, you can see the different slices here, the green sections, sorry, next slide, please. Yeah. So the green section showing the cost coming out of the health system, so between the position freezes, contract labor, and medical supplies. And then we have roughly $200 million being put back into the health system for the additional medical claims. So in total, the expense side of the budget is decreasing by $2 million. And with that, I'll pass it over to Joe to go through the offices.
Thank you, Scott, and good morning, everybody. Just give a brief overview of each of the offices. At Stroger, from FY '25 to FY '26, is looking at a $129 million decrease, as well as a 36 FTE increase, which is related to ARPA positions moving over to the corporate budget. Overall, the reduction is primarily attributed to the 10% reduction plan, which is carried over from mid FY '26, which is generally applied across all of our offices. Some of the other drivers are targeted focus on reducing agency in nursing, pharmacy, EBS, telecommunications, and labs, as well as some other areas, as well as continued service line investments and some volume growth for OBGYN, cardiology, neurology, oncology, and the cancer center. In addition, the budget contains some funds to replace the MRI equipment, renovating the sterile processing room department, as well as interventional radiology, interventional radiology room, as well as the parking garage. Next slide, please. At Provident, the budget is looking at a $20 million decrease, which is as well as a 9-position decrease, which is related to the 10% reduction plan, where some of these positions are moved over to the PCC, which we'll get to in just a second. However, there are some volume and expense increases related to the Crisis Triage Stabilization Center, as well as the expansion of OBGYN, urology, GI, oral and maxillofacial, and general surgery services, as well as the planning for a neurology stroke program that includes a new MRI facility. Finally, as it is an older campus, it includes facility infrastructure upgrades and investments for the aging campus. Next slide, please. On the outpatient side at ACHN and the Core Center, there is a reduction of $37 million as compared to last year, and an increase of 13 FTEs, which were related to ARPA. Again, the 10% reduction plan carries over, and this particularly focuses on agency utilization on our outpatient side, as well as the demobilization of the new arrivals intake center over at Belmont-Cragen. Additionally, it includes some funds for maintenance of facilities and repairs and upgrades of different clinics throughout the ambulatory network, as well as the Core Center. Additionally, there is the addition of oral health services at select ACHN centers, which includes Belmont-Cragen and Blue Island. And recently, we opened our 8th dental clinic at North Riverside Health Center. Next slide, please. On the correctional health side, at our correctional health facility is a $15 million decrease, with a reduction of 5 FTEs, again, related to the reduction plan, while JTDC is flat and has an increase of 2 FTEs, which came over from ARPA positions. The budget also includes the continued phasing of telehealth services, which continues to maximize the use of technology to provide efficient, effective, and safe services. Next slide, please. On the public health side, there's actually a $4 million increase, which as well as 41 positions that moved over from ARPA, and which offset the 10% reduction plan. There's also, this budget also includes different communication initiatives for expansion of advertising for the Cook County Department of Public Health Services to the public, as well as a new community immunization program, which partners with our ambulatory network. Next slide, please. And on the administration side, there is an $11 million reduction and an increase of 35 FTEs, which are related to the 10% reduction plan, which reclass generally non-union positions over to the Position Control Committee. And it also includes our continued investment in revenue cycles to manage our denial of reductions, increase claim submissions, as well as the utilization and improved billing technology for our electronic medical record system. In addition, there's the continued expansion of our life sciences department, which supports our research operations and grants, and is generally being expanded this year, as well as, again, the FTEs that are converted in the Position Control Committee as previously referenced. Next slide, please. And on the county care side, the budget as referenced is increasing by $210 million, which is again from the 5.8% increase to the PMPM rates, and has a 3-position reduction related to the reduction plan. And I'll get to in the next slide the membership rates, which the average is 362,000 estimated over the course of FY '26, which at the beginning of the year is approximately 377,000 and reduces down to just under 349,000 by the end of the year. Next slide, please. And continuing, this next slide, we'll go through each of the different county care plans at the top, and the acronyms are in the bottom left. And it'll show the projected memberships by each of the plans, as well as the revenues, expenses, as well as the net income for each of the plans, which looks to have a $1 million profit projected profit for FY26. And at the bottom is the contribution by each plan to the health facility, which includes about $103 billion in contribution margin, which are county care members utilizing CCH facilities. Next slide, please. And on the grants and ARPA side, if you can go one more, thank you. There is $69.2 million between grants and ARPA. ARPA is the American Rescue Plan Act, which these funds expire mid-26. So the $26.4 million here is related to different contracts and grants being dispersed to different programs. On the Cook County Health and Department of Public Health grant side, there's $42.8 million of different grants over 99 different initiatives related to behavioral health, opioid and substance abuse, food as medicine, emergency preparedness, trauma-informed treatment, and healthy children and families. So these funds are on top of the normal, or on top of the $5.144 billion, and these funds continue to help us provide services beyond the traditional healthcare and hospital clinical setting need. There's also 210.7 FTEs that are included in these different grants. And finally, on the last slide, this is our ARPA progress to date. As referenced that the funds are expiring, this is just showing our current expenditures and budgets for the year, as well as our plans to help expend these funds. And on the last slide is just different acronyms throughout the presentation, and we'll open it up to any questions.
So I have a question. Thank you for the report, all of you. I want to make sure I heard this right. How many dental clinics do we have up and running now?
I believe we have 8, and we have 2 more. We have 8, and we have 2 more set to open in FY26 at Belmont Cragen, and what was the other one? And Blue Island. Thank you.
In follow-up to this meeting, would you forward me a copy of those clinics that we have open? I appreciate it.
Yes.
I have a dentist at home who's acutely aware of everything we're doing. Thank you.
Any other questions? Hearing none, I will now accept a motion to approve item 3C, the proposed Cook County Health Fiscal Year 2026 preliminary budget.
So moved.
Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right, thank you. We are now going to review and consider the proposed 3-year financial forecast for fiscal year 2026 and through fiscal year 2028 strategic plan, which I believe, Pam, you're going to be approving that as well, or not approving, presenting that.
Sure. Thank you, Chair Ryder. So this is just a projection of the next 3 years that we include as part of the strategic plan. It's similar to the graph that was part of the budget presentation, right, that projected out the deficit in the future years. But it's just, this is shown a different way, right? So we have the revenue sections coming from the CCH revenue, the Cook County tax piece, and then the county allocation to the pension. And then we've broken out the expense side just by office, right? So we're projecting, of course, this year we're submitting for 2026 proposed a balanced budget. So it shows ending surplus or deficit of 0. But then in those out years, due to inflationary increases and raises and such, deficits of $100 and $200 million. And as you scroll down a little bit, Deb. Yeah. We've also shown the budget on an accrual basis, same information on an accrual basis, which includes just the timing difference between when revenues are earned rather than collected, and expenses are paid or owed rather than paid, I should say. And so you can see the numbers differ there in that case, again, but we hope to be balanced for 26. The deficits in the out years are a little bit smaller, and you can see the assumptions that we base these projections on listed there. Any questions? All right, thank you.
All right. Is there a motion to approve item 3D, the proposed three-year, financial forecast for fiscal year 2026 or fiscal year 2028?
So moved.
Second. Motion's been made and seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed, the ayes have it. You know, so that way we don't have to, can I do some things out of order since we already have Pam and team up here? Why don't we go to, first, I'm looking at the Roman numerals 5, Roman 5, items under the Chief Procurement Officer. And, first would be, grant award related items.
Sure. Scott?
Yep, all right. Okay, so yeah, we've got a couple of grants, here totaling, 1.25, so one, coming from the Illinois, Department of Human Services, and the second is a renewal, of the renewal for $50,000. Actually, they're both renewals.
Any questions on the grant award related items? Hearing none, is there a motion to receive and file item 5A, the grant award related items?
So,
Motion's been made and seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
aye.
Opposed, the ayes have it. All right, why don't we go to, the June financials?
Okay, so we got the June financials here for the first 7 months of the fiscal year. So on an accrual basis, we ended $107 million unfavorable to budget. On a cash basis, favorable by $27.5 million. The explanation is remaining largely the same from a net patient service revenue point of view. Continuing unfavorable due to lower than budgeted volumes and increases in charity care, whereas capitation continues to be favorable. County care financials coming in just under $23 million unfavorable. However, membership is strong at 414,000, which is almost 5% greater than budget. Next slide. So just taking a peek at the income statement here. Again, we start with the net patient service revenue, which is unfavorable by $130 million, but as we add in the capitation revenue, which is favorable by almost $215 million, total revenues favorable by $83 million. Our operating expenses are unfavorable by $186 million, which is comprised mostly of favorable variance on salaries and benefits of $78.5 million, and unfavorable on the medical claims expense line of $252 million. Next slide, please. So our waterfall here, again, just showing a different presentation here of the income statement really, so you can see the various pieces, with the NPSR and the medical claims expense being unfavorable drivers, and then the capitation and salaries and benefits being favorable. Next slide, please. All right, so taking a look at our volumes here, we've got average daily census of 308, which is lower than target by 3.2% at Stroger. Provident average daily census continuing to be below budget, but within or close to the recent monthly trend. And as a reminder, we did have 2 OBS units that were budgeted for, but didn't open when we expected them to. And the CTSU is running with a lower census than anticipated. ER visits lower than budget at both Stroger and Provident, and surgeries behind budget as well at Provident by about 24%, which is mostly endo and GI. And then on the ACHN side of things, we've got primary care 7.3% unfavorable to budget. And specialty care, 4.5% favorable to budget, due to oral health, psych, and, really just, a variety of, small variances in different areas. Next slide here. So you can just see the same information graphically here. You can see our volumes that have trended. They've been fairly stable over the last few years. And then on the top left-hand corner, you can see the outpatient clinic visits where that line is continuing to straighten out as the year goes on, and we're closing that some of that unfavorable gap. Next
I'm
slide.
sorry, can I ask a question?
Yep, sure.
Let's go back to the key volume and revenue indicators. Okay, I think the red speaks for itself. I am sorry, it's rough for me to sit here and not ask this question. What's happening and why is it happening? This is just a lot of money we're not getting.
This is volume, so yeah, that translates to revenue. But the reasons behind the volume variances, Dr. Turner and Donica would have to speak to what they're seeing in operations. And I don't think either of them are with us today.
Donica is on remotely.
So what I can share from a surgical volume, the Stroger surgeries, we are doing active process improvement, kind of a revamp to ensure that we're using our ORs effectively and that we're scheduling in. We have relatively high no-show rates, same-day cancellations. That's all that work is going through to address that. The Provident OR volumes, I'm sure everybody remembers, because of staffing with GI, we had to shut down for about 3 months, which set us way behind in terms of the budget month over month. We've now added back a provider there whose sole job is to basically get us back on track for those scopes, the scope volume for GI. He is doing over and above on a daily basis what that budgeted volume is, and we'll start seeing that catch up in July, or we're anticipating that we'll be back to budget, if not better, based on the additional volume that he's able to provide. So Provident surgery by end of year should be back to budget. We're hoping it'll be better than budget.
Okay, here's the question. The problems that we're seeing, they were not anticipated?
So the GI issues, we had 3 attending physicians out on parental leave at the same time. And yeah, so it just punched a big hole in our staffing, unfortunately. And that is, because of that, we had to kind of pare back services so that we were able to maintain here. Additionally, I'll say that I think the average daily census, at least for Stroger, we've had improvement on our length of stay, that shrinks the average daily census. So we've gone from an almost 8-day length of stay down to 6-ish, right? So by shaving those 2 days off every day, there's fewer heads in the bed, right? So we budgeted to a certain amount, but that was kind of with the assumptions of the current length of stay. So we've done work on throughput that now is decreased.
Let me ask you a question there. Mm-hmm. If the length of stay is reduced, then the income associated with that particular person there should increase. The profit should increase. We then should free up more beds that we can get more people in the beds. So why don't we see that increase increasing? We should see the revenues increase as a result of that, which is good from an operations standpoint. Fantastic.
Right. If there's people behind them, yes, that would in fact be true. Sorry. So yeah, that yes, and in general, I would say it depends on the contract, but yes, in general, you shorten your length of stay, there should be a better delta there financially in terms of that admission. So,
but I guess the question that I'm asking is, if we are improving operations, which again I applaud because that's where we want to move to, but why wouldn't we now also increase our scheduling to get more people in? Because I don't think we're lacking with customers, right?
Well, so ED volumes have decreased. That's something we don't necessarily have control over.
Right, volumes decreased, but that doesn't address the question I'm asking. That just says we don't have as many people at the top of the funnel, but still, we have a small portion that can only get through at a certain point. We have only so many beds, so many operating rooms. And if we still have a large contingency at the top, even though it's not as many, we still should be able to fill those beds, fill those operating tables.
For the OR, yes, and that's the issue with the process improvement. It's how efficiently we're using the ORs, how we're scheduling, how we're avoiding same-day cancellations, because that's just unused potential, right? So that's the work in the OR. I'm not convinced that we have a line of people behind waiting for inpatient beds. We do have capacity, so we, just as we shorten that length of stay, there's just additional open beds. So it's not that we have like a whole slew of people in the ER waiting for inpatient beds. So the OR piece, I completely agree. That's we're working on that process improvement to ensure that we're using them efficiently and that we're stacking patients in, you know, as efficiently as we can.
So we don't have enough people that are looking to be admitted to fill the bed. That's the statement that I think I heard.
I would say in general, right, if we're not seeing, it's not that we're turning patients away and just not admitting them as we decrease the length of stay. If there's patients behind them, of course they would be admitted, right? But if, you know, I'm not sure that the thread follows all the way through to say if we decrease length of stay, that there's an additional person behind to fill the bed every day.
I guess the question that I'm asking, because, and again, I don't know, but I'm looking at the census, and we still have a lot of people who need care.
Mm-hmm.
And oftentimes, they do need to be admitted. Now, maybe it's good not to admit them if they're not paying, because then that becomes a deficit. And again, everything I'm saying is purely looking at the numbers.
Sure.
It's not about not trying to give care to anyone. That's not what I'm doing at all.
Mm-hmm.
That's not my role here. My role is to look at the numbers. If we look at this, and the people are there, then it seems like it becomes more of a scheduling issue, even on the admission side, because unless you really can show me the hard numbers to say that we don't have the people needing it, I still have issues accepting that we don't have people behind it, because it just doesn't seem to pass the sniff test.
Mm-hmm. Mm-hmm.
And so if we look at an operational standpoint, if we're not putting them in the beds, then it has to be somewhere in the operations where it's dealing with the scheduling and getting folks in there. Now, again, we do recognize no-shows happen, and no-shows cost us a lot of money. Every industry, every operation has that problem. So if that's the issue, I get it.
Yeah.
And again, my questions are coming because I just heard everything that Pam said, Scott said, and I'm seeing a lot of red, and I'm not seeing solutions to the red. Because my question is, in this budget process, is it just to report the numbers, or is it really to show how we can function and operate at a level that would put us in the green? And so my questions may be completely out of line. If that's the case, we can talk, and then I'll make sure I put them in line.
Yeah, yeah.
Yeah, I don't think the question is out of line, and you did say you were working on it. When can we expect to see progress?
So Pam, I don't know when the GI Provident numbers will start to see it, but I know he started working in June. There's been a bit of a ramp up. I think July he was kind of getting back to our standard numbers. I'd say probably the August numbers we'll start seeing where he's outpacing and we're catching back up again.
But these are, on the slide, we do have the month shown on the right, 2 columns there, but these are year-to-date numbers, so we will likely be behind budget all year, right? Even if there is catch-up, you know, we might be able to close that gap. But
Right.
So when he started in June, this does show June, if you focus on just the right 2 columns. Probably next month when we come back, we'll see if it's impacting.
Okay, I'll stop asking questions, but I'm just trying to raise the anxiety, because if we don't do it when we got time,
right,
then now we put a strain on the whole system, because we're requiring more money to be poured in, and people are not getting well because they're not coming in. So if it's a function of we need to have Alex do something to tell people come in so we can help you, then maybe that's where we need to put some effort.
Yeah.
That's all.
Yeah. I completely agree on the surgery piece. I think the inpatient piece, we would hope appropriate admissions are happening, right? And that we don't schedule inpatient admissions, right? If we're having better primary care, specialty care, ambulatory access, in theory, that should decrease our inpatient admissions, right? We should be avoiding admissions right
The
now.
other thing we should see happening, if we don't have people coming into the bed, then we should see over HCH in, it should be increasing. Because
True.
we know they're gonna get sick, and they're gonna need help somewhere. So where's it happening versus unless we're seeing the ER just really burst its sink. Which then, if that happens, and they're coming in worse, then we should see them in the bed.
Yeah.
So, well, I mean, I think the anxiety is probably appropriately high, because the whole system that we've been operating under, elements of it for the last 5 years since COVID, when, you know, supplemental funds came in to deal with that public crisis, and the history we've had with building managed care networks and providing access, better access to folks since the passage of the ACA, is the structure around that is probably changed, and notwithstanding all of the immigrant healthcare is about to take, you know, is taking two double whacks. One is with redeterminations and other access points for our whole population, along with the funding that just went offline. We are stepping backwards in terms of our infrastructure on all fronts, which is going to which has a cascading effect, if, you know, that I know everybody's dealing with. So if we were in a situation with sort of the chaos that we had as we were building the system, I'm surprised that we're actually able to be this methodical, because I will at least say that I appreciate the folks that we have in this fight right now, and we are also, you know, going to be. So I appreciate your comments, Sam, because we should all have that high anxiety. I also appreciate the comments provided by our CEO. This is going to be some tough sledding like we've never seen before as we approach the next probably, I don't know, let's say the next few weeks through the next 8 years and beyond. Dr. Green?
Speaking of, well, thank you for that, but also never seen before. Here's a small comment, but nationwide, people that care about the populations we care for, history repeats itself. All of this can definitely be tied to a cascade that came from COVID. You have epidemiologically, you have the virion, then you have the fallout of violence, then you have the act. Literally, there's something called the Immigration Act of 1918, and it happens every 100 years. One of the things that I've seen some entities do is look at the act, and it happened 100 years ago, see what different systems, of course, we have different tools now, but there's some information in there historically that we can use to help us navigate it. And I know this may seem odd, but at the end of everything you do is for the benefit of the people you serve. And so you're speaking about the people in this room and the work that's done and the tensions that may be high. Some of it we've never seen before because we're seeing it with tools, but definitely this cascade we've seen before, and we found ways to get through it. So there's some opportunity there. I just want to take some of the, yes, there's anxiety, but some of it, the Immigration Act, some of the things they did, is just a repeat.
All the way down to the anti-masking movement that occurred during that same
Yes.
period of time.
Yes.
As a reaction to the flu.
And literally there was an Immigration Act that employed some of the stuff we're looking at now, and then different entities kind of found their way to navigate around it. So history always gives us tools that we can learn from, and some comfort if we, some comfort.
The only thing that I would add that's different is during that period of time, I think the threat to governmental structures was higher in Europe than it was in the United States.
But it was still the same threat.
The same threat, absolutely.
Yes, yes.
Bill?
Thank you, Chair. I think, Director Robinson, one point you made is very, very important, and that is the role of Alex and others in getting out the messaging of what we offer. Let's keep in mind, we've been talking about the census at Providence really since before Dr. Makaitis was in this role with his predecessor. And until a couple of years ago, we didn't even have ambulance access at Providence. And we didn't have that access for over 10 years. Now, what we've done recently, we have a new dialysis center, MRI center. We've got the stabilization unit for behavioral health care. We now have the provision of GI services. That messaging has to get out to the people. And because as I go through my district where Providence sits, a lot of folks don't know we offer all that. So I do think that's part of the solution. And I know it's not lost on Dr. Makaitis and others, but that is part.
I will share that in that same vein regarding Providence, we just had Alex pull focus groups together of people residing in that primary service area to better understand, to your point, Commissioner, the kind of perspective of the community and what they're aware of and what they're not aware of in terms of Providence and where those benefits might be in terms of saying like, hey, come get your GI scopes here. Hey, we have CTSC, so just to ensure that we're communicating in a more targeted way some of the gaps that we identified by engaging the community.
Focus can be really good if they're done right.
Yep.
Carry on?
Yep.
Okay, thanks. All right, next slide, Debbie.
Yeah, I think we'll pick it up from the payer mix slide, yep. All right, so, Medicaid, stable, at 52.9, I think it was 52.8, last month, and uncompensated care at 21%. Next slide, please. So our revenue cycle KPIs here, the AR, accounts receivable, continues to be, in the yellow, but the team is continuing to
Donica had her hand raised, earlier. Donica,
Yeah.
did you want to say something?
Or did the moment pass?
Okay, no problem. I think, I was just gonna weigh in on some of the comments that were made, but I think we're past that and we can circle back at the next meeting. Thank you.
Okay, great.
The accounts receivable, really a measure of the health of the accounts receivable. So we want to have the AR days to be lower towards the benchmark here. Roughly 30 days is ideal. The PFS team is continuing to work on the denied claims that occurred because of the Change Healthcare breach. So hopefully in the next month or so, we'll see those numbers come back down and those boxes turn green. The next slide, our net final denials. So overall, the governmental billing denials continuing in the right direction, and then our net final denials are below the benchmark of 2%. Our next slide, please. Sorry. Yeah, the charitable and public program expenditures. So at this point, projecting just over 600 million of the for the year, with the two main drivers being charity care and other uncompensated care. Effectively the top two lines there. Next slide. So our savings initiatives, not much change here. We're still on track. Everything is in green. We expect the county care contract negotiations benefit there to occur in the month of July. So we'll continue to be on target there. And then last but not least, the county care income statement. We're just continuing to be slightly in the red, so $23 million loss due to a medical loss ratio 1% higher than anticipated. But again, you'll see that the budgeted volumes continue to be under the actual, so favorable variance there. And with that, happy to take any questions.
Are there any questions for any of the folks on our team up here? Hearing none, thank you all.
Thank you.
I believe we're now, Charles, you ready? Charles is like, I only have 13 contracts to present. I was supposed to be in and out today.
Well, I know the much of the budget, Pam is trying to take the president, so that's all right. After all, I just spend money.
Yeah.
Try to do the best we can, though. Good morning, Charles Jones, Chief Procurement Officer. I'll be say 13 items, 12 of those, 12 contracts and one, expenditure. 9 of the 13 require responsive letters from, Business Enterprise Development, formerly, the Office of Contract Compliance. We have 4 back with 5 in progress. So with that, move to our executive sponsors.
Good morning, directors. I've got 2 items before you today. Both are 1-year extensions with no fiscal impact. They are just time extensions only. The first one is with the University of Illinois Division of Specialized Care for Children. We're required to contract with them by the state of Illinois to provide care management to a specialized population within our plan called Special Needs Children. And again, this is a 1-year extension. And the second item I have for you is with vendor Epstein, Becker & Green, again, a 1-year no-cost extension. They do regulatory and compliance reviews with us to ensure that we're in compliance with the mental health parity rules and regulations.
All right. Any questions for Aaron? Okay. Keep rolling. Next up, we have request number 3, which is being presented. Oh, by Dr. McCormick. Sorry, I'm looking at the wrong cheat sheet.
Good morning.
The floor is yours.
Good morning, Dr. Dan McCormick, the Executive Chief Clinical Officer. I'm here to present the the extension of contract for STERIS Management Services. Would revise this contract from April 1st of 25 through March 31st of 26, not to exceed a total cost of $400,000. STERIS provides us instrument repair for all of our surgical instruments, and that will again proceed this same contract, not to exceed $400,000 all the way through March 31st of 2026. The next contract is with Medtronic. This is a one-time capital purchase, Medtronic, for $171,000. This is to purchase ECMO services, which is portable heart-lung, used to transport patients, critical care patients, typically during or after heart surgery or other complications, over to a higher level of care if we cannot provide that. And current equipment is reaching end of life. And again, that's a one-time purchase of $171,000.
All right, thank you. Any questions for Dr. McCormick? We'll move on to request number 5 through 8, operations and development, being presented by Alejandro Corona.
Good morning.
Good morning.
4 items to present. First item is we are requesting to extend an existing contract with Cardosi Hyper Designer Group. This group provide interior and exterior wayfinding signage design at Stroger Hospital. No fiscal impact. We're looking to extend it for 12 months. Next item, it's a request to extend and increase the contract with Globetrotters Engineering. Again, another professional services through CAP. This is for architectural and engineering design services for Cook County professional building, particularly the revolving door project. We're looking to extend it for $86,880. The next item is a request to execute a new contract through an RFP. This is, am I looking at the right one? Sorry. Skip one. Yeah. To execute a new contract with Chicago Abortion Fund, Chicago, Illinois. This is for the ACHN community clinics. This is to provide reproductive health services to women across Cook County. And it's for a 12-month contract, a total of $2 million. It's a grant fund.
All right, any questions for Alejandro? Or we got one more?
One more, yeah, sorry. It's another request to execute a new contract with Anchor Mechanical for HVAC services for the ambulatory community clinics. It's a 3-year contract through an RFP totaling $1,055,000. Thank you.
All right. I want to say that and I want you to report back that the comment was that you eclipsed Craig in the presentation of your report.
I don't know if I can say that to my boss. Thank you.
Don't worry, someone else is gonna tell him probably now. Yeah. All right, we're gonna move on to request number 9 through 12, and, Donica is on the line. Donica?
Yes, thank you, Chair Ryder. The first one is an extended increased contract with Cardinal Health 200 for distribution of laboratory supplies in the amount not to exceed 200 million. The revised contract period of 8/1/2025 through 7/31 of 2026. The vendor is a prime distributor and key manufacturer of our laboratory supplies, and the pricing available through this agreement reduces our cost of the laboratory supplies. The next one is an extend and increased contract with Advanced Imaging Specialists for temporary radiology staffing services in the amount not to exceed 416,322. The revised contract period of 5/1/2025 through 12/31 of 2025. The vendor will provide staffing services for temporary placement of radiology personnel to support our imaging modalities in CT, MR, nuclear med, ultrasound, mammography, and our PET CT. We currently have 3 technologists at Stroger and 1 at Department of Public Health at Arlington Heights. I just do also want to note that the leaders continue to review the staffing needs in our imaging areas and are certainly working at all times to match the vacant PIDs with our needs in the department. And obviously, our whole team at Stroger and broader are working on reducing our agency and attracting and retaining, in this area, technologists into CCH. This contract will be rolled into the new RFP awards. Our next one is an extend and increased contract with Relay Health. This is for our pharmacy claims management in the amount not to exceed 200.
Hey,
I'm sorry.
Donica?
Yes,
We just did yeah. Can we go back real quick to the, radiology contract?
yes.
Number 10. Because this is, deals with, services, agency type of services, can, I just have someone walk us through how this is going to impact our overall agency reduction plan? I know that this is a short-term, extension, but I wanna, make sure that we're staying on track with everything. I see Win at the table.
We'll work with Donica and team to ensure that this follows our process. So as we've talked about over the last few months, and I'll talk about a little bit more in the next presentation, we have an agency reduction plan. We have a process we use to bring agency on, and to Donica's point, we'll make sure that these match up with PIDs, and we'll go through the appropriate process before we bring any agency on board.
Just want to highlight that as clearly as possible. All right, thank you. Sorry.
Thank you.
Back to 11.
Okay, the next one is an extend increased contract with Relay Health. This is for our pharmacy claims management in the amount not to exceed 20,000. The revised contract period of 8/1/2025 through 10/31 of 2025. The vendor will continue to provide the pharmacy with the pharmacy claims management services. The vendor provides solutions to streamline the communication that happens between the patient, the providers, and the payers of pharmacy. This request is a sole source because the vendor already has a customized solution to fit the pharmacy needs related to our 340B program.
So I was just having a sidebar with our CEO, and he, this obviously is something that we also do in-house as well, and Eric indicated to me that this would fall in our accelerated hiring plan and is part of the mix as well. All right,
Thank you.
all right, and then,
And
Medtronic,
then the last one that I have is executing a contract with Medtronic for our peripheral vascular supplies in the amount not to exceed 600,000. The current contract period of 9/1/2025 through 8/31 of 2028. This request is for the provision of the peripheral vascular supplies designed to address the wide range of vascular conditions, including our peripheral artery disease, our venous disorders. This product is utilized by the interventional radiologists in the division.
all right, now we're going to request, thank you, Donica. Any questions for Donica? Now we're gonna go to request
Thank you.
number 13.
No question, but you're right, I want to state before Dr. McCormick starts. For request number 9, I want the record to reflect that it's $2 million and not 20 million. 200 million is stated. It is written correctly.
It's $2 million? Okay.
She said 200. For the record.
All right, I have, number 13 here, which is an expenditure approval for New Care Symphony Services. New Care provided short and long-term care nursing home services for unfunded patients discharged from Stroger inpatient facilities. That expenditure is for $382,088.80.
Any questions for Dr. McCormick? Hearing none, thank you. That brings us to the end of the contract procurement items. Charles, do you have anything to add before I take a motion?
Yes, sir.
All right, I would entertain a motion to approve item 4A, contracts procurement items containing request number 1 through 13, subject to completion of review by contract compliance.
So moved.
Motion's been made. Is there a second? Motion's been made. Well, do we have a second? Second. Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? The ayes have it. All right. The report of contracts executed under CEO authority, Charles?
Yes, sir. Thank you. You have before you contracts under $150,000 for the second quarter. March, April, and May, contracts executed under authority of CEO. It was 15 items. All 15 are responsive with the Office of Business Enterprise Development. 7 of the 15 are TPO vendors, and 11 of the 15 are for our capital equipment purchase as we buy down our FY25 capital. Highlighting a few of the larger dollar ones, close to 100,000 above. It's Evidence Scientific. This was a capital equipment purchase for microscopes for pathology and Provident Laboratory, $146,000. Hall Render, Hillman and Heath, legal services for the Office of General Counsel. They provide specialized healthcare law, $149,000. Innovative medical devices. This was CardioQuip modular heater cooler systems for surgery, specifically for open heart patients, $132,000. And then we did a maintenance service contract with Redimed for preventative maintenance on pumps and monitors in the Department of Radiology. That was $90,000. Any questions on the report?
Any questions? Hearing none.
All right. Thank you.
Thank you, Charles. We're now going to move to our agency reduction plan report, and we're going to have it presented by Wynn and our Chief Human Resources Officer, and Adam Weber, our Executive Director of Special Operations.
I don't believe Adam is here, so I'm not sure if Wynn's gonna do it.
Yeah, I think
alone.
Wynn's flying solo, it looks like.
I'm gonna do my best version of Craig today.
Okay. You can do a Boston accent?
That was a bit of a problem. I actually can't do that.
Okay. Good morning, Wim Buren, Chief Human Resource Officer. Let's see, first slide, current state of hiring and separation. So we've made 1,310 total offers with 971 accepted. We filled 744 positions, or actually 890, that's up from 744 FY24 this year, or same time last year. We've had 247 internal candidates promoted and 643 new hires. So nearly 28% of filled positions in 2025 were from internal moves, supporting career development and retention. Separations increased slightly from 335 in FY24 to 347 in FY25. But that's been offset by a slightly higher hiring volume. Net year-over-year growth jumped from 165 to 260 or 296. So we're looking at about an 80% increase year-over-year, signaling a strong workforce expansion and retention. So any questions on the slide?
Any questions on that slide?
All right.
Keep rolling.
All right. Current state of agency use. So this report analyzes the monthly headcount and percentage of agency staff from September of FY24 through June of this year. We've seen an agency headcount decline. Agency staff numbers fell from 1,380 to 925, so that's a 33% reduction in the last 10 months.
Why? Go ahead. Why?
I'm sorry.
Why did we see the reduction? Because we have vacancies. Why are we seeing a reduction?
We have converted many of the agency folks over to our organization. So that's the work we've been doing over the last 10 months with the agency reduction plan, and then hiring, and then either demobilizing them or bringing them on board.
Yeah, this is what we've been reporting on every month.
And there's another piece to it as well. I think we talked about a little bit earlier. So we didn't have a great set of controls in place in the past. So we are currently ensuring that before we bring any agency on, we're running it through the proper process, which is partnering with BHR, making sure that we have a PID to match up against that. So that's another reason why this has fallen down. So we've got better controls in place now as well.
Thank you.
And this includes, does this include everything that we've added other contracts into this? This is the cumulative, including
This is, yeah,
from the Department of Finance, everything, right?
Yeah.
Okay. So that's good progress, even as we've layered in things we've discovered along the way.
And what caused the uptick in December, January, and February? Just curious. We were trending down, then we went up, and now we go back down.
we went up in December. That's typically seasonal. So we had seasonal hiring needs then, and then we were able to go back down.
Okay, thank you.
Okay. So this is a new slide. So all these positions were part of our contract conversion project that we did earlier this year. As you can see, significant gains were achieved in reducing agency use by position. I believe this is something that the committee asked for last month. The above noted positions were some of the highest agency usage in 2024. MedTechs are a good example. In November, we did not have any vacancies in the lab for MedTechs, but we're using a significant number of agency to meet the minimal operational needs. We added 45 positions into the department's budget in FY25. There are several factors that impacted hiring for MedTechs, one of which was market pay and equity. We've been collaborating with the union to rectify this and anticipate more successful recruitment efforts in the near future due to the changes in pay grades. Most significantly, our building services workers decreased from 107 to 15 since the beginning of FY25. This is in large part due to the success of the conversion process and added vacancies into the department's budget. Okay, so this is another look at the top job code agency use. So total FTEs, as we kind of discussed.
Hey, can we go back that slide? I just want to. Those numbers are dramatic. Yeah. I mean, I just want to take a second and just say that. You know, I know we've heard a lot of comment on things that we still have to fix, that the numbers are the other direction. But if you look at what we've been working on for the last 10 months, and these are percentages, not hard numbers, but I think we just saw the hard number count on the slide before, which includes everything, including things we are still in process of figuring out. And those numbers have come down dramatically, but just looking at these percentages in that chart, holy shit, you know? That is striking. So, obviously, you know, there's numbers that we still want to get down, quite a bit, but, you know, considering like a medical technologist, and I don't know what's the hard number on that?
We have 45 openings, total budget is 65. So we're working through some things. We think that in the fall, after we finish up some work with our partners.
So it's a relatively small, number of employees relative to the overall.
Correct.
So that'll be, once we get that one, I mean, we've already reduced, but you can move those numbers quickly by hiring,
Absolutely.
you know, doing some conversions or hiring. So we should see a continued dramatic impact on that. The ones that I think were our highest head count were probably food service worker, building service worker, I would guess. Am I right about those? And
Yeah, building service, we had 107 at one point in time. Went down to 15.
yeah.
It'd be helpful to see those numbers relative to the change we're seeing.
Okay.
That provides the context we don't have.
It might be on the next slide.
Not in that format, but we'll take that and
Okay,
make
all
sure
right,
that we,
yeah.
as we kind of work through this for the next version of this particular slide, we'll add that in there.
Okay.
Help me understand this for a minute. The 250% or 260%, what does that really mean?
We had more agency workers in place than we had PIDs at the time. So we had to add in, it was to cover, it's what we needed for coverage, but that's part of what the settlement agreement was about. We didn't have positions, but we were using agency workers. We didn't actually have PIDs for it.
Eric is picking up some of this from the next slide. If you want, why don't you? Stop interrupting me, Siri.
So we're saying in that first bullet point that we had 260% more agency workers than we have actually staff from
Yeah.
the organization. Okay. And then we look down at the next one, that number is now 59.5% more.
And by the way, I think one of the things that's important, and I think Wynn just touched on it, is one of the issues that we had to overcome, but also one of the issues that people, I think, under our decentralized system, took advantage of, is that they were able to utilize the agency contract to bring more people in without PIDs, without positions, to staff it. So we had people in there, but through a contract, because we didn't have vacancies to hire people into. So instead of us fighting to, you know, and we don't live in this universe by ourselves, so we have to talk to downtown about this. Downtown has given us the positions to be able to convert some of these people in. We had some vacancies to work with, but we didn't have, some of these we had to get open positions in order to, you know, keep that head count the same, going from agency contracted employees over the CCH direct employees.
And for these positions that we're looking at, how does the relative cost compare?
We're typically going to pay a premium for agency. I don't have the exact numbers on me, but I can make sure that we look at that as well.
It's cost savings, depends on the job, but
Yeah.
there's a delta that we pay as a premium.
Across the board?
Well, for anything.
I know you.
Not for everything, because
That's the question I'm asking.
there's some contracts, but they're very few, where they're like the call center contract has been brought up. You know, we don't know what the economics are around that because it's offshore, it's anything, you know. But that has a different element to it, and there's probably still, there could be still some leveling factor because, you know, depending on having, insourcing some positions, you get better efficiency, and you get better training, and, you know, the lower labor cost is offset by, you know, other problems that you have built in there, which we have to work through.
So there's really two lanes, right? There's that traditional agency, which is what we've been really working on for the last year or so. And then in the last month or two now, we've been talking more about some of the contracted services and looking at those things. So that's where there may be not that delta and the cost savings baked in, is through the contracted service. Agency across the board is you're gonna be paying a premium for a third party to source staffing in to come to work in vacant positions.
So that premium is gonna be larger than the all-in cost on an employee.
Yes.
Okay.
That's the premium. You're paying above and beyond what your cost is.
Okay.
Okay. Good. The next slide has more of those hard numbers, if folks want to look at that. Takes you through the journey.
Yeah, so, total FTEs decreased for agency from 1,380 to 925. Obviously, this speaks to the deliberate effort we've made to reduce reliance on agency labor, optimize costs, and restructure operational workflows. We still have some challenges. We have areas where we need to improve that we're working on very deliberately. For instance, clinical nurse one remains the largest job code, comprising 36% of our actual agency usage. Major reductions in support roles. We've seen ward clerks decrease by 92%, building service workers, patient care technicians, and transporters decrease as well. Medical technologists, phlebotomists, and radiological technologists saw moderate declines. Again, I think we mentioned earlier that 45 new medical technology roles were incorporated into the 2025 budget.
And if you want to see the illustration on the hard numbers, it's right there for you to see, because you can look at that. You can look at that first orange column and then carry it over to the last orange column. You'll be able to see the beginning to date difference. I mean, the building service worker number is just incredible. Word clerk as well. Yeah.
Okay, and then this is our local tenant slide. So between February and June, we saw a modest increase in the use of local tenants. This trend suggests rising demand in key clinical areas. We went up by about 10.5% between February and June, with behavioral psychiatry seeing the greatest increase. The number increased in May and June due to hiring needs for the Clinical Triage and Stabilization Center, so CTSC, at Provident. We've hired staff and have staff in the pipeline, so we should see this particular number drop in the coming months.
So we're taking cues for where we're seeing surges in those clinical areas.
Yeah, absolutely. And then I believe is Dr. Sprenka online?
I am. Good morning, directors. So,
We can't
continuing,
hear you. You're very
can you hear me now?
A little better.
Okay, I'll speak up. Good morning, directors. This is Mark Sprenka, Chief Scientific Officer. Pleased to report continued progress in transitioning folks from Hectone to MEDEX and MEDEX to CCH. As I've reported in the past, the first stage of this effort is completed. We completed that several months ago. The second stage is not in fact, an actual transition. It's an opportunity for folks who are sitting at MEDEX to apply for positions at CCH, which we then review, and we make a decision about whether or not to offer a job. That latter process is going well. To date, we've posted 48 jobs, and that's led to 37 offers being extended, 35 offers being accepted, and 35 folks being onboarded to CCH with these numbers are accurate as of a couple weeks ago, with 16 were scheduled to be kind of onboarded by the end of July. So we're approaching the halfway point in this staffing effort. We expect with the continued collaboration with HR and finance to complete the remaining staffing efforts by the end of the fiscal year and hopefully sooner. Happy to take any questions.
Any questions?
Yeah, for my clarification, are we saying 35 people are onboarded and we have onboarded in July 16 additional people? Or are we saying, how many people out of the 112 people are onboarded right now?
So 35 plus 16. So
35
that
out
would
of
be
112.
35 plus 16, so a total of about 51 out of,
So 50, okay.
out of the 97 who, so a total of 51 out of the 97 who are at MedX.
Okay.
So we're a little bit over halfway completed in this process.
Okay, thank you.
Are you at the end?
Yes. That is all.
Any other questions? If not, thank you, Wynn. All right. I think that brings us to the very end.
Chair Ryder,
Yes.
what happened to the clock that used to be on the wall right here? It's been missing for a while.
I
Jumped over there.
Oh,
Sam? I have a request. Dr. Robinson, is there a request to, so you
no,
can have
I'm
your
okay,
countdown?
but I've been wondering for about 2 or 3 months,
Yeah.
when the clock was gonna come back, but that's fine.
You know, if we can, and it's
No request, no
No,
request.
I got one for you. If we can, I don't know within the county system, if like the city, we have any pool facilities, but I'd like to get one of those lap pool countdown clocks. We could put there. Yeah. You say his name 2 more times, he may show up. All right, with that, I believe we are at the end, and the agenda is exhausted, and we are adjourned. Thank you.